Hi everyone, I'm Lee-Fay, and today I'm going to talk about conceptualizing dementia stigma. This is meant to be a provocative talk, so my job is to convince you that how we've been thinking about stigma isn't working, and maybe we need to think about learned behaviors and focus on those. If you tell people you have dementia, you will lose your income, lose your driver's license, and be treated like an idiot. We know that dementia stigma is really pervasive. An international study with over 700 people with dementia from 33 countries found that 83% of them reported discrimination in one or more areas of their life. So what is dementia stigma? The common psychological conceptualization of stigma is that stigma comprises negative beliefs, such as that nothing can be done about dementia, or people with dementia have lost their minds in an empty shell. Those negative beliefs are associated with negative feelings, very commonly fear, shame, pity, and disgust are words that come up in relation to dementia. And they lead to negative behaviors, avoidance of people with dementia or avoidance of a diagnosis of dementia, discrimination against people with dementia, and overprotection of people with dementia by carers, health professionals, and possibly even the system. Let's talk about what we know from the literature about the consequences of experiencing stigma. Most important, I think, are the consequences for people living with dementia, including delayed or postponed help seeking and treatment, feeling ashamed, and some people have said humiliated, being socially isolated, not being included in groups or social situations anymore. Many people with dementia have said friends fall away, they just don't call anymore. People with dementia also talk about loss of social status, not being seen, being invisible. They talk about low self-esteem, withdrawal from activities because of this loss of status and lack of inclusion. And we know that people with dementia who are recently diagnosed have increased risk of self-harm and suicide. And also they really find it harder to get insurance. Carers of people with dementia sometimes tell us that they feel ashamed or guilty, they feel socially isolated or abandoned. I mean, this differs from person to person, the experience. Some carers are more reluctant to ask for help. We certainly know about the high risk of burden and depression in carers, so it's not universal. And we know that some carers delay help seeking and accessing services because they don't want to identify as being a carer or identify as being a carer of someone with dementia. In the public, we certainly have heard many studies now reporting that, number one, after cancer or surpassing cancer, dementia is the health condition that the public fear the most. And we also see lots of jokes about dementia. It's no longer appropriate to make jokes about gender or jokes about race, but we still see lots of jokes around dementia and memory loss. For health professionals working to support people with dementia, it's lower status employment, lower pay, so aged care nurses get paid less than nurses in the hospital system here in Australia, and there's less training and support around dementia, though this is again changing. Hasn't been much support for professionals working in dementia to date. Reflected, I guess, in the health system stigma around dementia is that we really have very poor data around dementia, even though it's now a national health priority. And there's poor identification of dementia, which complicates management of other health conditions. Let me unpack a little bit more stigma-related behaviours, because if we want to intervene to change these behaviours, then we need to be clear which group we want to change and what specific behaviours we want to change. In people with dementia, there is a lot of self-stigma. People with dementia deny or hide their difficulties. They avoid help seeking. They often avoid social situations and tasks which might show their difficulties, even though those things are things that they used to enjoy. And very often they do not identify with others with dementia. They don't want to be in social groups or support groups with people with dementia because they're not like people with dementia. Carers, unintendedly and often with very good intent, take over tasks and decisions. The doctor tells them, you're now going to have to go in a carer role, you're now responsible, and often they try not to put the person in public on social situations in order to protect them. The public don't really like talking about dementia. It's one of those things we don't talk about, like menstruation. The public avoid and include people with dementia socially, and they're really disinterested in the topic. Dementia is not relevant to them until it becomes relevant to them, and they have a family member or they themselves are experiencing symptoms of dementia. But otherwise, they don't really want to know about dementia. Professionals, well, we've been trained to make some assumptions about capacity, and we're not very good at involving people with dementia in decision making. We tend to talk to carers rather than the person with dementia. In care settings, we often use elder speak, and we make biased judgments about the potential benefits of interventions, meaning basically we say that people with dementia are not rehabable and we don't offer them interventions which people with dementia might benefit from. In the health and other systems, we often disregard the rights of people with dementia, and locked memory units is a prime example of that. Some of the systems assume incapacity. So in our in ethics, we used to have to kind of justify that people with dementia could consent because they were vulnerable. They could consent to be for themselves for research studies. And in the system, people with dementia are excluded or have reduced access or are low priority for some services, and also excluded from many research studies. Until recently, probably the last 10 years, the focus really has been on services for carers rather than services specifically for people with dementia, though perhaps this is changing. Unfortunately, we really don't know much about how to decrease dementia stigma, and a lot of the ideas from this talk I've drawn from the mental health stigma literature, where there have been many more studies and much more thinking conceptually around stigma. Let me tell you about a scoping review of stigma dementia interventions. The team identified 19 evaluations of interventions to reduce dementia stigma. Most of these studies were small pilots, though there were some larger studies with Ns ranging from 8 to 450. Most of the studies targeted the public, and interestingly, mostly the public were children or youth or health students. 9 of the studies used education as their intervention, such as presentations or theatre performance and film. For example, Dementia Friends is an education intervention. 8 use contact as their intervention, for example, intergenerational choir, dance, or storytelling. And I did say that there were quite a few studies with children or youth. And 2 combined education and contact, for example, dementia-friendly kayama. The scoping review found that the interventions tended to improve dementia knowledge and attitudes, and a few studies measured and found improved behavioural intentions, but none of the studies measured actual stigmatizing behaviour towards people with dementia, and no studies measured how people with dementia and carers felt in terms of the amount of stigma that they received. Summarizing the evidence for stigma interventions, then, we don't really know much about how they impact on people living with dementia or carers. We know a little bit about the public, particularly younger people in the public rather than older people. We don't know much about professionals, though there are studies looking at stigma risk reduction professionals that weren't really included in this review, and we don't really know much about stigma interventions to impact on the health and other systems. Like I said, there's really no evidence around enacted stigma, so behaviors that are stigmatizing, or experienced stigma in terms of interventions to improve these. So it seems like stigma interventions are modeled on this cognitive rationalist idea that negative beliefs lead to negative feelings, lead to negative behaviors. This is the model perhaps that CBT originally was sort of set up on, cognitive behavioral therapy, that even then we know that it doesn't really work directly that way. We intervene with beliefs through education and training that we can fix those beliefs and there'll be flow-on effects to behaviors. We also think that perhaps contact with people with dementia as part of events or on a committee might impact on negative beliefs and negative feelings, and that will improve those negative behaviors. I'm not sure that this rationalist cognitive assumption is the right way of thinking about dementia stigma. What if they don't relate in the same way at all? What if improving knowledge doesn't mean that we're going to change behavior in any way? So how and where do we learn about dementia? Jess Baker led a study where we talked to kids about what they thought about dementia. Most of them didn't know very much. And what they did know was about dementors, these scary creatures in Harry Potter that suck out the life and soul of you. And I think that actually a lot of what we know about dementia, or vaguely know about dementia, we get through the media, and perhaps we also learn by observing our families and other people around us and how they interact and feel, I guess, about dementia. If we are learning about dementia from the media, then how is dementia reported in the media? We conducted a systematic review of 60 papers reporting on public depictions of dementia. We found that dementia was almost always portrayed as being related to old age. We found that dementia was almost always portrayed as equating to Alzheimer's disease, and sometimes these terms were used interchangeably. The symptoms of dementia, how it's depicted, were related to memory problems, disorientation, decline, and death. Treatments, cure, and positive depictions of dementia are rare. The way dementia was depicted created a sense of social distance between people with dementia and the audience. If dementia is a problem of aging, and sometimes mixed up with aging, we can't tell the difference between dementia and aging, we really have to talk about ageism and this deep belief that we all have somehow, that young is good and old is bad, and people saying, I'm not old, because they don't want to identify as being old. And a sociological conceptualization of dementia stigma might be more useful. So stigma happens because there are two groups. We see ourselves as us and them. We're separate. There are differences in status and power between us and them, in which case dementia interventions need to remove us and them and bring us closer together. I think education can't just be teaching people facts about dementia, but rather bring forward the unconscious bias that people have and call up the behaviors that we want to change and the negative feelings that we want to change. The other approach that we could try is to reduce social distance, which does happen in contact interventions, but really more explicitly modeling positive behaviors around people with dementia, and also working more closely with the media on how dementia is depicted. I think if we think of dementia stigma as an extension of ageism, another type of discrimination like sexism or racism that's really deep-seated, and to change dementia stigma, we also need to use techniques that we've used in other places, where we really change publicly how we all behave around and with people with dementia.